Okay, go ahead.
Great. So hello, everybody. My name is Joji Suzuki. I'm an addiction psychiatrist here at the Brigham Women's Hospital. I'm the director for the Division of Addiction Psychiatry and also the program director for the new Brigham Addiction Medicine Fellowship program here. I'm truly delighted to welcome everybody to the second in the series of on opioid use disorder around the globe, a speaker series sponsored by the program in Opioid and Pain Innovation, or POPI, and also the HMS Harvard Medical School Center for Global Health Delivery. As an addiction psychiatrist, just like Scott Weiner sort of mentioned last time, who moderated the session last time, I've witnessed the toll the opioid use disorder has, taken on to our communities and our patients and their families. What's been frustrating is that we've done so much work in the last 2 decades, yet it's become very clear that we still have a long way to go. And that's partly the reason for this, is that for the speaker series, is so that we can learn from others who have been, dealing with these issues, potentially with different solutions and different approaches, than what we focused on. So we've had a really wonderful session last time. We heard from speakers representing the US and Canada, where it became very clear that there were some similarities, but also some stark differences in the approach that we've taken as a healthcare system in responding to that crisis. And so I certainly walked away from that feeling like there's still so much to be learned from one another. And I'm sure today's speakers will also provide the same feeling for us. So as such, I'm honored to introduce the two speakers we have scheduled for today, who hail from Germany and United Arab Emirates. So the first speaker will be Dr. Heino Stöver, who is a professor of social scientific addiction research at the Frankfurt University of Applied Sciences in Germany. Since 1987, he has been the director of the Archive and Documentation Center for Drug Literature and Research at the University of Bremen. He is the president of the national umbrella organization working on harm reduction for drug users called Accept ED. I'm not sure if I'm pronouncing that correctly. Since 2009, he has been the director of the Institute of Addiction Research, and his main area of research and project development are in health promotion for vulnerable and marginalized groups, drug services, prison healthcare, and related issues. He has been a consultant for the European Commission, the UN, the WHO, European Monitoring Center for Drugs and Drug Addiction, the International Committee of Red Cross, and Open Society Institute. So highly accomplished speaker. And our second esteemed speaker is a Dr. Hisham Elarabi, who is a consultant at the National Recovery Center in Abu Dhabi, United Arab Emirates. He brings over 20 years of experience in mental health treatment and research, overseeing landmark trials like the Suboxone Treatment Rehabilitation Trial, or STAR-T, in collaboration with the Institute of Psychiatry, Psychology, and Neuroscience at the King's College in London, and setting the stage for a paradigm shift in the safe access to treatment of opioid use disorder. Dr. Hisham Elarabi has previously held many roles, including health education and research, and contributed to establishment of school and family-based prevention programs, policy, advocacy, and legislative amendments, and to the transformation of treatment and care services within UAE. So both are highly accomplished speakers, so very eager to hear more. And so we'll start with Dr. Stöver, and then immediately following that, we'll have Dr. Elarabi speak, and then we'll go into Q&A. So Dr. Stöver, please take it away.
Okay, many thanks, Georgie. So I will share the screen with you and go into my presentation. And I will focus on a setting which is not talked very much about, and that will be the state of opiate substitution treatment implementation in European prisons. So that's what I'm talking about. So we will learn a little bit about evidence, obstacles, and progress, and risks, and so on, and then I will come to the conclusions. I think you will get the presentation anyway, so you can look after certain issues. So guiding principles of the worldwide healthcare delivery of prisoners are the Nelson Mandela rules. This is the renamed form of the prison standard minimum rules from 1955. They have been revised and have been given the new name after our most famous prisoner in the world, Nelson Mandela. And the principles, they are guiding our work throughout the globe. And I will especially focus on Rule 25. It says the provision of healthcare for prisoners is a state responsibility, and prisoners should enjoy the same standard of healthcare that are available in the community, and should have access to necessary healthcare services free of charge without discrimination on the grounds of their legal status. And the second paragraph of that rule says healthcare services should be organized in close relationship to the general public health administration, and in a way that ensures continuity of treatment and care, including for HIV, tuberculosis, and other infectious diseases, as well as for drug dependence. So these are the guiding principles. And what we are discovering in prison settings is many people who inject drugs and who are affected with infectious diseases, and that is due to unprotected sex in prisons, multiple sexual partners, low and inconsistent condom use, intravenous drug use, incorporating the sharing of syringes, needles, and drug use paraphernalia, and tattooing and body piercing made in prison. These are among the principal drivers of the global HIV epidemic, and makes prisoners to a key population named after the WHO guiding principles, so very important to keep in mind. And people who inject drugs are especially affected with HIV, STI, hepatitis B and C, TB prevalence is 22 to 15 times higher than in the general population, and TB incidence rates even 23 times higher. And we will see here what is being discovered in many countries in the world, according to the UNAIDS GAP report. I will focus on a special case of Germany. We carried out, or a study has been carried out by the Robert Koch Institute, which is the Central Health Monitoring Institute in Germany, so-called drug study. And this study found out only recently that drug users asked in the community, they admitted to 81% that they have been incarcerated. The average duration in prisons was 5 years. On the average, 4.6 times imprisoned. 30% of those ever incarcerated injected while in prison, and 11% of those ever incarcerated and injected while in prison started their intravenous drug use while in prison. And these are alarming figures, which should give us a sense of prevention. And the prevention tool which is being applied throughout the world is this HIV comprehensive package by WHO, UNODC, ILO, and this comprises 15 key interventions, of which I would like to highlight only one, the drug dependence treatment, and that is meant opiate substitution treatment, because for this intervention we have got the most evidence that it works in most of the prison situations. And I will focus on another German point, which came to the European Court for Human Rights in Europe. And this is the case of Wenner, Mr. Wenner versus Germany. And this is highlighting the OST practice in parts of Germany. Mr. Wenner has a manifest and long-term dependence to opioids. And his opiate substitution treatment continuity has been denied by the Bavarian prison authorities. The court went after several stations to the European Court of Human Rights in Strasbourg in France. And the court found that the physical and mental strain that Mr. Wenner suffered as a result of his untreated or inadequately treated health condition could, in principle, amount to inhuman or degrading treatment. And the failure to adequately assess Mr. Wenner's treatment needs involved a violation of the prohibition of inhuman or degrading treatment. And that said that law is more powerful than science, because the practice in Bavaria has been scandalized by many articles and has been figured out by research study results. So let's have a look at OST, the evidence, obstacles, and the progress we made. There's one very important cohort study done by Sarah Larney already in 2014, enrolling 16,000 people, opiate-dependent people who were in prison between 2000 and 2012. This study showed that being an OST was associated with a 74 lower hazard of dying in prison compared to times not in OST. Being an OST was associated with 87% lower hazard of unnatural death compared to time not an OST. And being an OST was associated with 94% lower all-cause mortality hazard during the first weeks of incarceration compared to time not in OST. And finally, being an OST was associated with a 93 lower hazard of unnatural death during the first weeks of incarceration compared to time not in OST. However, looking at the global level, the availability of OST in the community and in prison is quite diverse. We look at here the countries in red, showing that OST is available in the community, and the gray ones, OST available in the community and in prison. So we see here still a number of countries which have not introduced OST in the prison setting. But also looking at the countries who are marked in gray here does not mean necessarily that OST is, let's say, covering the whole country. There are huge differences and diversities within the countries. And looking at OST introduction in Europe, it says that there is a huge time gap between, let's say, official introduction of OST in the community, that means the yellow line, or in the OST in prison, the green line. Looking at countries, for instance, Netherlands, who have introduced OST in the community very early, already in the 60s, it took more than 20 years to introduce it into the prison setting. But also other countries, Germany did it rather late in the community, and at the same time, more or less, they did it in the prison setting. But others took some more years to introduce it in the prison setting. And when we look at the European picture, in green, we see here all prisons in these countries have implemented it. In yellow, in orange, that means OST is available in some prisons. Looking here at my country, Germany, and Poland, in yellow, we do not have that much data about that. That means treatment is possible, officially available in all prisons, but low coverage due to additional requirement for abstinence. And in red, we see here not introduced yet. We did a study on the European healthcare delivery in prisons, especially for the focus group, the target group of opioid-dependent people. We see here that OST has been introduced in some countries to a large degree. See here, sorry, you cannot see here, the champion has been run down is UK with approximately 25,000 prisoners in OST, then France, 15,000, and then Germany with approximately 1,700. So that takes me here to the case that only in a few countries the prevalence or the coverage rate is quite high. We see here Slovenia with 44%, 29% UK, and you see here in blue, the blue bars, heroin use before imprisonment. That says that the coverage rate is rather low. That is, however, also, although we've got a lot of European documents recommending OST on a national and international level, we've got the Council Resolution 2002 on drug treatment, the European Parliament recommendation on the rights of prisoners in the EU. We've got 2 EU drug strategies which emphasized to do OST in prisons. Yeah, we've got Two principles, I mentioned that already, according to the Nelson Mandela rules: equivalence and continuity of care. But national policies vary from that. Historically, in prison health, historically, healthcare is within the ministries responsible for prison, mostly the Ministry of Justice. But some countries changed the responsibility for healthcare delivery from justice to health: France, Italy, UK, Norway, and Sweden, and so on. This process is ongoing and is based on WHO recommendations. And some countries have a mixed models, and the plans are the 12 countries with prison healthcare objectives in national drug strategy. 9 countries cover drugs in their prison health strategy. This is according to the European Monitoring Center for Drugs and Drug Addiction. OST is available in all countries except 2, Greece and Slovakia. There's a large variability in coverage, but I said that before, not available in all prisons. In Germany, in Bavaria, there's a huge gap, and waiting lists as a maintenance treatment or detox. Methadone, mainly 70%, buprenorphine, due to control barriers, only in 30%, provided by external providers, only a few, and due to our study, mainly used as a continuation from continuity, and only 8 countries we found OST was possible to initiate while in prison: Austria, Estonia, Finland, France, Greece, and so on. The percent of prisoners receiving OST, more than 10% coverage in 7 countries, 3 to 10% in 9 countries, and less than 3% in the other countries. You see here already the quite low range of coverage. It is rarely connected with psychosocial interventions and care. England and UK, they have an integrated drug treatment system, but that is located only in the UK. We've got variable doses from 100 milligram to 21 milligram in other countries, increasing OST provision, but still low in prison. And there's a distinction between formal guidelines, a recommendation, and actual implementation. Little information is available in many countries. We carried out a systematic OST review of the impact of OST in prisons. We found 21 studies, including 6 RCTs, show that OST is effective among the prison population to a high degree, reduced heroin use, injecting and syringe sharing in prison if doses are adequate. It increases in-treatment entry and retention after release. It reduces post-release reduction. It supports post-release reductions in heroin use. Pre-release OST reduces post-release deaths. The evidence regarding crime and re-incarceration is equivocal. We've got a lack of studies addressing effects on incidence on HIV and hepatitis C. So what we found is the disruption of continuity of treatment, especially due to brief periods of imprisonment, is associated with very significant increases in hepatitis C incidence. We've done a guideline on how to do OST in treatment. This practical guide is now under revision. The next version will come out in autumn. To sum it up, where have we gone from here? The coverage still is quite low in most of the countries. The detox models are very heterogeneous. The maintenance varies. OST as relapse prevention is only functioning in few countries, and OST provision in prisons varies from country to country, from region to region, from prison to prison, and even from doctor to doctor within the same prison. That is the result of a European study we carried out. Why is the introduction of OST going so slow? Still, the abstinence construction is predominant. The concept is predominant in prison. Some of the doctors have juridical concerns. There's a lack of knowledge. We've got a lack of infrastructure. mixing up of OST medications with street drugs by staff and medical doctors. Most of them think methadone is a street drug, is a drug and not a medication. And some concerns we heard about political reasons that prison directors or the person in charge for the healthcare delivery in a region and for prisons is not in favor of OST. However, several doctors did not understand that they are independently working with doctors. They are the family doctors for prisoners, and that is the role they've got due to their oath of Hippocrates and the medical oath. Conclusion: so prison-based OST is highly effective that means of treating opioid use disorder. OST is a starting point and stable therapy for treating other disorders and infectious diseases like HIV and hepatitis C. Highly effective of reducing the risk of death, 75% reduction among people in the first 4 weeks after release from prison. And these are definitely, let's say, advantages where we should go for. And we see a slightly increase in the number of OST patients in the prison setting, but still lacking behind the needs and the current needs we have with regards to HIV and hepatitis C prevention. Many thanks for your prevention, and I'm looking forward to our discussion later on. Thanks a lot.
Great. Thank you so much, Dr. Stöver. That was very fascinating. You're right that we probably should be talking more about the prison population. So looking forward to discussing more. If we can now move on to our second speaker, Dr. Elarabi. Please put on your video and share your screen.
Thank you so much, everyone, Tim, Sue, the panelists for inviting me. And I really appreciate the opportunity to be among this panelists, and listening to Professor Stöver was very enlightening, especially that we are on the edge of developing a prison-based program. I would also want to share the greetings and thanks from His Excellency Dr. Hamad Al-Ghafri, who is the Director General of the National Rehabilitation Center. I'm sure he would have been very delighted to listen to Professor Stöver, as he's a great advocate for prison-based programs. Now, please allow me to move on, focusing on the current situation of opioid use in the UAE, the burden and the policy interventions, what we think has been an innovative approach. And if I'm going too fast, please stop me. I just want to be within the time frame. I'm not, I have no disclosures, and I'm not presenting any off-label use for any medications. These are the contents that I'm hopefully in the next 18 minutes I'll be able to cover. But before that, please allow me to give you a little bit of context on the situation in the United Arab Emirates. The UAE is geographically located close to production zone. I mean, we are talking here about Afghanistan, some countries of Central Asia, Pakistan, Iran, transit and destination country. For many years, we thought that the UAE was only a transit country, but it is a destination country, apparently. There is a rapidly changing landscape of substance use in absence of a comprehensive surveillance system, which prevents us actually or limits our ability to paint the current and real-time picture of the substance use. However, what we know very well over 20 years is that opioid use is the drug of choice, despite of this rapidly changing landscape, and it represents up to 40% of total substance use. In the UAE, imprisonment or using substances is a criminal offense, just for using, and imprisonment has historically extended up to 4 years. I'll talk about that in the policies because this has been changed in 2017. However, no criminal proceedings are enacted when individuals seek treatment voluntarily. This is a UNODC map where it highlights areas of the red is where opioids are highly used, and if you see here on the under the circle, the UAE is close to these countries where the opioids are commonly used. And it is on the major trafficking routes. Again, this has been extracted from the UNODC drug situation report or World Drug Report. Moving, I just need to highlight that the treatment in the UAE has been established. A drug response center, the National Rehabilitation Center, which I happily present today, has been established back almost 20 years ago. And it had a mandate of a comprehensive drug response center. So it wasn't only treatment and care, but it looked at the whole continuum of care, research and innovation, prevention, early intervention, human capacity building, training, policy and legislative development and advocacy. The only, despite this spectrum of mandate, it is located in the capital of the UAE, which is Abu Dhabi. There's no network of services that follow the NRC or a part of the NRC. We became a WHO collaborative center in 2017. The challenges that we have seen, in addition to the situation analysis or the context, is that the capacity, as I said, is limited, not only in number, but the spectrum of care and geographical distribution. There is limited access to medication-assisted treatment, as Professor Stöver mentioned, and is only provided by the NRC. No other facilities across the country provide medication-assisted treatment for maintenance. There is limited availability of the service of medication treatment, particularly because of the reports of diversion, non-adherence, possibly abuse, and because majority of our patients do present with polysubstance abuse. Over 2/3 of them come with 2 or more substances other than the opioids. And to add to it, of course, stigma. And here we're talking basically on social and structural stigma. The epidemiology in the UAE, you're not a big country geographically, but hopefully with our achievements, we strive to achieve better status. Up to 0.28 of the population were estimates. These are estimates of the current opioid users in the UAE. There has been an increase of 526% from 1990 to 2010, which is significant. Mortality is 0.23%. And I want to share with the next few slides, some of the profiles, just to understand how the burden or the impact of substance use, opioid use on the population here in the UAE. You'd see that our patients start significantly early, which is 17 years. They spend almost 11 years until they present to treatment. So in the best years of their lives in youth, they are being distracted with substance use. Family history of use is up to 15%. We don't have comparisons to that, but it seems that it is significant. Majority of the users are injecting drug users of the heroin. less of prescription drugs. So the pattern of use is basically illicit drugs. The prevalence of hepatitis C is higher than B, but both attribute or contribute to 12% of the population. As I mentioned, polysubstance use is quite common, and pregabalin is among the top ranked. The non-fatal opioid use, non-fatal overdose, is 24.8%. And the proportional risk hazards to develop a non-fatal opioid use overdose is 3.8 times higher in polysubstance use, and particularly in those who are using cariprazole. I think the equivalent of it in the US would be Soma. It's a muscle relaxant. Moving again with the patient's profile, almost 2/3 would have mixed anxiety depression. When it comes to mood disorders, over 75% have sleep disorders, and that has an impact on the number of psychotropics prescribed for patients. The mean was accounted for 1.5 psychotropics other than opioids substitution treatment. And the range was every patient would probably receive up to 4 different psychotropics. I have not commented here on the medical comorbidities because we're still studying the medical consequences of substance use. But I can say that hopefully soon we will be able to release information on the medical consequences and its matched control. Economics, disease burden, if you want to translate it using the WHO metrics, it's 0.1, opioid use represents 0.71 of total dailies. And in a population-based economic assessment, the total substance use disorder, so here we're not specific to opioids, represents 1.4% of the gross domestic product. The classification of this number is, regardless of the numbers, I just covered the percentage of the cost. 88% is contributed to by productivity loss. Criminal justice system costs represent 12%. Compared to, we did a patient-based study using a psychometric tool, and we looked at how this disease burden would change compared to the economic methods that was used in estimating the disease burden. We found that the mean imprisonment episode was 1. So every patient technically was imprisoned at least once. Majority of the contribution of the disease burden was due to the cost of drug purchase, and productivity loss was not as high as what was reported by the economic methods. So this is just a comparison between the economic and psychometric methods. Our responses, legislative. The first response that had a huge impact on the number of patients coming into treatment was reducing the sentencing from 4 years to 2 years for illicit substance use, and expanding that concept of voluntary treatment seeking by extending it to those who have been reported to use substances and coerced treatment by a first or a second degree family member. So patients who don't want to come to treatment and they still constitute a disturbance and harm to their families can call the drug enforcement authorities and they will coerce them to treatment. Inception of drug course is still a legislative bill, basically for post-sentencing. So it would start, drug courts would start within the time of sentencing. And this might be one thought that Professor Stöver can consider. We previously, we never had the reason for cultural reasons, the reason of death reported for opioid use. Now there is, this has changed, and death certificates would come up with not only a hemodynamically unstable patient, but a positive opioid use. Health insurance does not cover substance use disorder in the basic coverage, and this has been introduced. The government covers the treatment directly. In the harm reduction policy, we started to distribute the naloxone emergency kits for first responders, the naloxone auto-injectors for individuals and families with history of caresprodol, because we know that the overdose, non-fatal overdose incidence or proportional odds ratio is higher. It's 5 times higher than those who are not using caresprodol. We started to monitor patients with polysubstance use closely who are placed on medication-assisted treatment using buprenorphine. And we started to generate, look more on the hotspots to inform the departments responsible for early intervention and prevention. And the next slide would show just a small snapshot of the geographical difference. In Abu Dhabi, which is where I'm talking to you from, the prevalence or the use of prescription drugs here being tramadol was a lot less than Dubai, which is located in the northern part of the countries. And that's why we looked at reasons why this is the case and have informed our early intervention and prevention programs to address this. Innovative prevention, innovative interventions. We looked at the reasons why there is not enough coverage of treatment and tried to demonstrate the cost benefit of treatment. That went through a public relations campaign demonstrating the economic harm of substance use, and that this is a problem that the whole community has to be responding to. Then we expanded our work to come up with a intervention that monitors both adherence and abstinence, coupled with contingency management, because we found out that that's the only behavioral management that has an impact on substance use. And in this contingency management, we use unsupervised doses as the incentives. No, previously or currently, before this study, patients had to come on an observed treatment daily or at least twice a week. With this study, this is just a screenshot of the study that has been recently published in Addictions 2021. And we've used therapeutic drug monitoring in monitoring the adherence, and we can send patients up to 4 weeks at home and be able to know whether they're using the drugs as prescribed or not. Within the innovative interventions, we have looked at what is the impact of family engagement on treatment, and we realized that it increases the retention by 3-folds. But apparently parents or families do not contribute to treatment as expected, possibly because of the stigma, family stress. This is a small community. At the end of the day, everybody knows everyone. So we developed a family-centered program that is now being delivered using digitized platforms. It helped, of course, the COVID helped this approach because people have more acceptance of digitized or virtual programs delivery. That's the publication that we had. I will close with the success and the failures, the moving forward. What were our successes over years? We knew ambulatory care is much better than extended residential program and institutionalization. We know now that medication-assisted treatment should not only be limited to detox or short-term treatment, but has to extend to maintenance. And we know very well now that recovery-oriented systems of care are more realistic than absence-based approaches. There are a couple of things on supply reductions, which I will skip for the sake of time. The conclusion recommendations, we want to redefine the treatment outcomes. So opioid use should not be the only treatment outcome. We should look at other things like retention, social recovery, impairment, etc. For the clinical component of the buprenorphine monitoring adherence with buprenorphine, we are developing a prototype of a point of care which would we assume it would help greatly introduce this into mainstream treatment. As Professor Stöver mentioned, pre and post-release prison programs are under consideration. And of course, the impact of social and individual stigma on treatment, demand for treatment and social recovery and reintegration. With this, I conclude and thank you so much. This is my references. And these are some sites from Abu Dhabi. If you would like to visit us, try not to do that in summer, but hopefully in fall, it will be a much better weather. Thank you.
Thank you so much, Dr. Stöver and Dr. Elarabi. Those were both phenomenal lectures. I've already learned a lot, and so it's remarkable to hear about the experiences in other countries. So I'm just going to start off with some questions that I have. I know that people will be adding questions to the Q&A feature. So if people have questions, please go ahead and add it to the Q&A feature there. I just want to quickly ask, one of the struggles we have in the United States and other places really is about stigma against the medication treatment, no matter what the setting is. So how were you able to really get the buy-in from the prison system to be able to deliver medication treatment? It sounds like many of the European countries have been successful in that. The US, I'm not sure exactly nationally what the data is. Here in Massachusetts, we've actually mandated the provision of medications, but that was since about 2 years ago. But it's still not widespread. There's a preference for naltrexone. So Dr. Stöver, I was a little surprised to hear that it's mostly methadone, and I didn't hear about naltrexone. And Dr. Elarabi, I'm not sure in your case what the medication choices are, but how did you get buy-in from prisons, and what are some of the medications that are being used there?
Mm-hmm. So if I may answer for the first time, stigma and discrimination is a very hot and important topic to be dealt with in prison settings, but everywhere in healthcare delivery. When I did an inquiry in opioid use disorder and medication-assisted treatment in Europe in 2006, 2007, I visited many countries and many prisons. I've seen more than 100 prisons in Europe in that time. And in some prisons, I saw a shield at the door saying, here an addicted person is living, a cell plaque, a cell shield saying, here an addicted person is living, pay attention, staff member. And that was the, let's say, the ultimate form of stigmatization of people in MAT, medication-assisted treatment. And I think, meanwhile, many countries changed their politics and practices, knowing and being sensitive for this stigma issue. What I suggest in countries where I do some support in prison regimes is that to treat medication-assisted treatment as any other medical treatment, any other health provision. Try not to let other prisoners and staff members know what is the exact reason of the visit of the medical doctor in the prison yard, in the medical yard, in the medical unit. Try to think of medications with a depot effect, like we have buprenorphine depot medications in many prison systems meanwhile. Asking the prisoner for, do you want to have a 1 week depot or do you want to have a 1 month depot? Both is possible now. And that reduces the number of visits in the medical unit, of course. And it's a good technical way of avoiding stigma and discrimination. But anyway, I think we have to more and more look at in how far the prison system itself is stigmatizing people, and to avoid stigma from other prisoners. But also in some countries, I found that other prisoners, they're quite in line with this sort of treatment. They're not envying it once they're not in treatment. They are accepting it, and it needs, of course, sort of an education of both staff members and prisoners on the basics of MAT. And that's not rocket science. That can be done quite easily. That can even be done on a peer level, from prisoner to prisoner and from staff member to staff member. Prison doctor plays an important role, a pivotal role, I would say, and nurses. They have to, let's say, make clear that this is a medical treatment like any other treatment: blood pressure, insulin, diabetes, whatever.
Great. No, thank you for that. And it's nice to hear that the injectable versions are available. In the US, we don't have the weekly version available yet. It's just a monthly version. So that's really fascinating. Dr. Elarabi, anything to add in terms of the stigma issue in the prisons and how you're able to get the buy-in from the prison's correctional system to treat this as a medical illness, like Dr. Stöver says?
Thank you so much. I think with the increasing number of patients or inmates due to substance use, the prison systems have started to look at alternatives because of the overcrowding, particularly, and because, of course, they relapse and they keep coming in again. It's a revolving. So I think they were kind of ready, primed, and it was our role to introduce, as Professor Stöver said, the medical component of it, and ensure that this is going to help, let's say, address the current problem of prison overcrowding. But I'm not sure we have done enough with the prison system to introduce treatment within prison systems, but definitely there is a demand from the prisons currently for treatment-based programs in their setting.
Great, thank you for that. There's a question from Syed Shah. You've entered a number of things in there. Would you want to ask that question yourself? You can unmute yourself, and Gloria, I'm assuming Syed Shah can do that to ask a question.
No, I don't think she can. So
unmute yourself.
I think you may have to actually access for her.
So
okay.
Do you hear me?
Go ahead.
Okay.
Yeah, we hear you.
Okay,
yeah, we
thank
hear
you. So my question is, what, the 40% is opioid use, people coming to the center. So what is the 60%? What are the major drug abuse in the 60% of cases? And my second question is, what is the proportion between national and non-nationals, and what is the ratio between gender, like males and females? So I will appreciate this answer.
And I think that was meant for Dr. Elarabi. So proportion of local versus non-national, I'm assuming that means immigrants, I'm not sure, and gender ratio and...
Thank you for the question. Just wanted to highlight that according to the mandate of the NRC and the UAE law, constitution, that everyone, as Dr. Stöver said, has the right to access to treatment. So regardless of the ratio of nationals to immigrants or residents in the UAE, treatment is provided to all. But just to answer the question, it is 20% are nationals and 80% comes from other countries. We have 181 nationalities living in the UAE. The 60% patients, as I said, it's a there's always a changing landscape, but I can tell you that prescription drugs was high in 2015. Then there was stimulants, and basically Captagon, and alcohol. I can confirm that our exposure to cocaine, whether it's in whatever form, in powder or paste or crystalline, is very limited. I hope this answers the question.
Mm-hmm.
Great. For those who may not know, Captagon, we actually did see a case of that here in Boston. It's rare to see that. I know that it's much more common. It's interesting that the patterns of prescription medication misuse, I'm forgetting if it's Dr. Elarabi or Dr. Stöver mentioned pregabalin, also Captagon, and also carisupperdol, which are, of course we see them, but, not to the same extent. I was actually kind of, Dr. Elarabi, you mentioned the primary drug of choice that patients seek treatment for, up to 40% is opioids. That's a remarkable number, because obviously for us, alcohol by far, and then cannabis and others, represent a higher proportion. Now, one of the things that go ahead, Dr. Stöver.
No, so many thanks, Dr. Elarabi, for mentioning the changes in the prison sentencing policy, and I think this is very interesting. And also, one person, Scott Weiner, here in the chat, is mentioning that the reduction from 4 years to 2 years for drug consumption. I think can be seen as a major step forward into to bring people into other directions, because the prison is not the most suitable place for treatment starting, and for the treatment as such. And UNODC and WHO and many other international organizations, they have come up with alternatives to imprisonment. I think the simple fact that people are dependent on drugs, and they did something to finance and to finance the drug use, should not be, let's say, reason enough to imprison them for years. And this does not lead, I think, to any positive effect, or only in a very few anecdotal life stories, I would say, that I would know from my experience. Certainly there are some people who would say the prison was saving their lives, but this is only a few people. In many others, we saw that in my chart from the Robert Koch Institute study, it is a revolving door policy. Prisons see the same persons, and Dr. Elarabi mentioned that as well. They see the same persons all the time. And the sentence in prison does not really bring them away from drug use. Many thanks for mentioning that, Dr. Elarabi.
Thank you.
Yeah, and I would agree with Dr. Weiner's question about whether this has an impact on outcomes. Would be a fascinating thing if data is being collected around that. Another question. My understanding is that Germany has implemented quite a bit of harm reduction policies around safe consumption rooms, et cetera, similar to what Canada has done. In the US, that's really not been something that's been well supported politically. I don't know if you have any comment about harm reduction services in Germany and what the experience has been.
So yeah, we've developed quite some harm reduction measures. For instance, drug consumption rooms. In 8 of the 16 states of Germany, drug consumption rooms have been installed. That sounds a big number, and in some parts it is, but still 8, on the other hand, 8 states denied to give, let's say, the juridical basis for implementing such a drug consumption room. It's a north-south gap we're feeling. I'm based here in Frankfurt in our institute. We are monitoring the 4 drug consumption rooms in Frankfurt, and we are seeing more or less 200,000 drug consumption events per year in these 4 drug consumption rooms, and they're saving lives, definitely. I think the policy is split a bit. We have a lot of really harm reduction measures on the ground, but at the same time, we've got a very repressive policy in many ways, that police and law enforcement is very, very active. And so it splits a little bit. On the one hand, harm reduction, on the one hand, a very repressive system. Imprisoning lots of people simply for use or surrounding offenses to finance their use. And that is let's say, the structural contradiction we are living in. And we should harmonize that in a way more than we did before. It's a political thing. We've got general elections in September, and we are awaiting a new coalition, middle left, and that I think will change some things at least.
So that's interesting. Even in Germany, there is a split. So that's interesting. Dr. Elarabi, any comments around harm reduction approaches that are available in UAE?
No, we don't have any harm reduction, but at least labeling it under harm reduction might be by itself a barrier for cultural and political reasons. But you can also deliver, I mean, everything what we do is harm reduction one way or another. Endorsing a recovery system of care is a harm reduction. It's just the terminology, as Dr. Stöver said. Some people would accept it and understand the benefit behind it, and others would never agree to it.
Yeah, I mean, that's exactly what we're trying to deal with in the US, and we face similar struggles. One of the things that's happened in North America is the explosion of synthetic opioids in the form of fentanyl. It sounds like in both countries, that we've heard from, the overall prevalence of opioid addiction remains relatively low and has not seen the explosion that we've seen here in North America, both Canada and the US. Are there any thoughts on why that is and why you've been able to prevent just sort of the horrors that we've experienced here in North America?
Yeah, I'm currently working in a European research project on synthetic opioids called Are We Prepared? And we did some basic interview studies with experts from Canada and the US. But indeed, apart from the Eastern Europe countries like Estonia, who has seen a fentanyl epidemic in 2010 and a few years onwards, fentanyl coming from Russia, this is not very widespread, fortunately. So we've got some anecdotal things to see and confiscate by the police, but fortunately, these synthetic opioids are not, let's say, very widespread in Europe. And also in Estonia, the crisis has been overcome, so that let's say the fentanyl crisis is now has come to an end.
Great. Dr. Elarabi, any comments on that issue?
I think we share the same experience with Europe. We don't have an explosion of fentanyl. However, our early warning centers have showed that there have been laces of fentanyl with the illicit heroin or morphine. So it comes with the substance, but people are not demanding fentanyl on its own.
Great, because in the U.S., essentially, for example, here in Boston, patients cannot get heroin. It's simply not available. Fentanyl has taken over almost completely. We have a question in the chat from Rosemary Pomponio. In U.S., drug use is paid for by criminal activity. How is drug habit supported in UAE and presumably Germany as well?
Of course, mostly by criminal activity. So sex work, burglary, betrayals, drug dealing, drug smuggling, drug producing in a way. Out of the 160 estimated opiate dependent persons, 80,000, that means half of them are in OST and in MAT treatment. And that reduced the negative cost for society substantially. So we should be very lucky to have with MAT a certain treatment, medication-assisted treatment for substance use disorder. We don't have that for other substances and other substance use disorder, and we should apply it as much as possible with no waiting list, and extend it and expand it wherever possible.
Great. Any final comments, Dr. Elarabi? Great. So Dr. Stöver and Dr. Elarabi, this was really phenomenal. I think all of us learned a tremendous amount today. This has really been a meaningful series to hear from experts like yourself, so we can learn a lesson or two. I hope that, I know the attendees had a bunch of questions, and I hope that folks will continue to listen in on the additional series. I think we have 3 more. Gloria, I think we have 3 more to go. So we're very excited and eager to hear additional speakers in the coming weeks. So thank you everybody for your attention and joining for this wonderful series, and hope to see you in the future events. Thank you so much.
Thank you. Have a great afternoon. Thank you.
Thank
Thank
you
you.
as well. Bye-bye then.
Thanks, everyone.
Thank you.
Bye. Thank you. So, Gloria,
That was
Sadiko?
great.
That was
I think
great.
that was great. Yeah.
Yeah, I
So
thought that was really
the
really
full
well.
hour, as